more women are being diagnosed when they present for infertility. And then, of course, the hormone replacement, menopausal hormone treatment replacement. So there's really quite a lot that we are going to look at in this talk today to see how we can personalize, individualize, and give the best outcomes to women with this cancer. I will also say here, this is one of the cancers where the average gynecologist has a very important role to play. It need not be a super specialist one. It need not necessarily be a gynae oncologist. Even the routine practicing gynecologists will be able to handle nearly half of the cases satisfactorily, but we must know which are those ones. And so I think this is a talk which should be very relevant to everybody. Now, if we look at the epidemiology, we see that it is the 6th most common in females worldwide, and it is the 2nd most common amongst the gynecological malignancies. Further, we see that it is the most common gynec malignancy nowadays in the developed countries, but in India, it has now become the 3rd.
They were telling TH.
Which is not a lot, but the main thing is that it is increasing. So if we look at the number of cases and the number of deaths in the US, we can see how they are showing some rise at a steady pace. But if we look at the results, this is, for example, the Chennai registry. If we look at the reports from Delhi, there's an annual increase of 5%. And this is largely due to the lifestyle factors that are bringing more and more of these cases to the front. In fact, I had the good opportunity to lead this consensus document for management of uterine cancers for ICMR, and a lot of people around the country contributed to this. And we could find that amongst the risk factors, we saw that nulliparity and anovulation are very important risk factors. And all of you, I'm sure, deal with all of this regularly because PCOS is such an important thing coming up now. Similarly, the increasing incidence of diabetes and obesity is causing the relative risk to go double to 2.4. And so we have to look out for all of these factors and tell the patients. And as the familial syndromes go, we know about BRCA and ovarian breast cancer and all that, but for C. endometrium, Lynch syndrome is a very important one. It's not so common in India yet. And having said that, many things we don't think are common because we don't look enough for them, so we don't know. But we must bear this in mind that Lynch syndrome makes the relative risk 20 times more, and 3 to 5% of CM and endometrium are actually harboring Lynch syndrome. And in these patients, the screening has to begin at the age of 35 years, doing annual hysteroscopies, endometrial biopsies, and advising the risk-reducing surgery, which is the total hysterectomy, which can be laparoscopic very well, with the bilateral salpingo-oophorectomy at age 40 or even earlier once they complete their families. So this is the most important amongst the familial ones for this one. In fact, in SGO, in NCCN, they have recommended that all newly diagnosed women with endometrial cancer should get the screening for Lynch syndrome, and especially those younger than 50 years for the molecular changes, which we are going to discuss. Now, this dualistic model has been known for a long time, the type 1, type 2, and the type 1 is the one we normally see, which is about 80%. 80% of the tumors who are relatively younger, these are the ones who are obese, unopposed estrogen use. And the precursor lesion is atypical endometrial hyperplasia or endometrial intraepithelial neoplasia. These tumors are low grade. There's a low likelihood of myometrial invasion, of LVSI, lymph node positivity. Rarely you get extrauterine mets, and they have a good prognosis. And the mutation characteristically are the P10 KRAS mutations. But if we see the type 2, then this is the non-endometrioid variety, though it is only in the 20%, but this is the more worrisome group. They are older women, they're not necessarily obese, estrogen excess is not a risk factor. These are the serous endometrial carcinomas, which are the precursor lesions. And these high-grade tumors have a higher likelihood of myometrial invasion, of lymphovascular space invasion, of lymph node positivity. Extrauterine metastases are present in 70% of these cases who have a bad prognosis, and these are with the P53. So this is the classic dualistic model Bachmann classification, which we have known since 1983, and we are all familiar with this one. Now, the classification by WHO has come out in 2020, which has brought in this very clear categorization. But I am not going to dwell upon this because this is not something that is affecting you as a practitioner. We are more concerned here today with the advances that were brought about by the Cancer Genome Atlas Research Network. This TCGA reported a comprehensive genomic and transcriptomic analysis of endometrial cancers, and they categorized them into 4 genomic classes. They studied the endometrioid, serous, and mixed endometrioid and serous type of carcinomas. And then they now looked at them not as a dualistic Bachmann 2 types, but as 4 genomic classes. They called them the poly ultramutated, the microsatellite MSI unstable, hypermutated, the copy number low, that is the endometrioid, and the copy number high, that is the serous-like. So these 4 types are what they got by running this complete proteomic analysis, and they could see these 4 different types of tumors. And they could see when they looked at them by the progression-free survival that there was a clear distinction of outcomes, with the poly having the best survival. This is the progression-free survival, which is seen here going down up to 10 years. And then it was followed by the copy number low, the MSI, and the copy number high, which were like the serous. So I don't want to go into trying to make you memorize any of this, really speaking, but just to tell you that this poly ultramutated is the one which is similar to our type 1 tumors, usually high grade, superficial invasion, very good prognosis, and no real need for adjuvant therapy in this group of patients. The MSI-H, the hypermutated, which is all the tumors of the Lynch syndrome, and these are mostly endometrioid, occasionally non-endometrioid ones too. The copy number low, which are the ones which are the majority of the C endometriums, actually 39%. And because these have increased progesterone receptor expression, there's a potential responsiveness here to progestin therapy, and the copy number high, which are really corresponding to our initial type 2 story mainly, where the worst prognosis is seen and the predominantly serous histology is seen, and they are about 26%. Now, this actually was such a convincing difference in the survivals that many people have been pushing to make a molecular staging of endometrial cancer. But since these are things which are not yet being done routinely in practice, therefore it was resisted that we should not make this into a universal FIGO staging. Other molecular classifications were also developed by other groups. There was the Leiden molecular classification, which looked for the poly, MSI, NSMP, and the P53, and the Vancouver group who worked out that this is the way you could start looking at a new sample, look for the MMR, deficient goes into one category, intact, look for the poly, They're mutated, go into one category, wild type, look for the P53, and then you decide whether they are P53 present or the P53 abnormal, wild type or abnormal, and go accordingly. So what did this summary result in? It resulted that you can see these 4 groups, which you can classify based on the mutation, of course. A very, very good histologist might actually be able to see the histological differentiation to an extent with this. The diagnostic test should essentially be on these mutational analysis. Out of these, the most easy to do one, which is routinely done by our pathologists really, is the P53. And among the clinical features, the younger age, we have seen the poly, the Lynch syndrome in the MMR deficient, the P53 at an advanced stage, and the NSMP at the higher BMI. So here, excellent prognosis, spare them chemotherapy, radiotherapy, maybe a role for immunotherapy, MMR deficient, intermediate prognosis. This group is sensitive to radiation. And if they get metastatic disease, they are good for immunotherapy. The P53 have poor outcome, but yes, they may benefit from chemotherapy plus radiotherapy. And NSMP as an intermediate to excellent prognosis and a response to hormonal therapy. So that is to say that with this methodology, we can make sure that we spare the side effects of adjuvant therapy, except for those patients who are really going to benefit from it. Moreover, we can decide who gets no chemoradiation, who gets only radiation, who gets chemo plus radiation, and who gets hormonal therapy if we can quantify this. Let's talk about the precursor lesions. Again, we had the old definition of simple hyperplasia and complex hyperplasia without atypia and with atypia, and the risk that there was an underlying cancer associated with them, or the risk that they would progress in the near future to it varied from 1 and 3% when there was no atypia to 8 and 29% with atypia. And that is why we have treated always a complex hyperplasia with atypia very seriously, because we know that the final histopathology of the hysterectomy specimen may yield a cancer even if the endometrial biopsy or aspiration did not show it. But now the newer classification which came removed this simple and complex classification, and they came out with this classification saying hyperplasia without atypia, coexistent invasive endometrial cancer less than 1%. If this relative risk of progression is 1.01 to 1.03, then you have the atypical hyperplasia or the EIN, where the coexistent invasive carcinoma is up from 25 to 33%, and their relative risk is 14 to 45. So this is where the serious part of it lies. The diagnostic evaluation for a patient who comes with a postmenopausal bleeding, or if you want to see a case where there is any kind of a suspicion of there being a problem, is the transvaginal ultrasound. And I'm sure this is something which everybody is now familiar, that at a cutoff of 4 mm in a postmenopausal woman, it has a sensitivity of 96% and a specificity of 53%. And because it is something which is at a 5 mm cutoff, a very good sensitivity specificity as compared to the 3 mm, this is considered to be good enough. But if there is a patient where you have a high suspicion, then even with a lesser mm cutoff, you may go ahead for further evaluation, because we know that some cases will be missed out when you take a higher cutoff. So the endometrial aspiration can be done very simply as an OPD-based procedure, and the PIPL and the Vabra have long been used and shown to be effective. And we have often used just a 4 mm common cannula with a 20 ml syringe, which gives us equivalent results. So as we saw that TVS, endometrial aspiration, even a normal endometrial thickening, if you have bleeding, do the endometrial aspiration. And because even this will have a false negative rate of 5 to 10%, follow it up with a hysteroscopy and DNC if there is still a high index of suspicion here. What is the role of hysteroscopy? Well, if you have a focal lesion like a polyp, you have an inconclusive EA with persistent symptoms, as we discussed. If you can see fluid in the cavity, a direct cavity visualization gives a sensitivity of 83 and a specificity of nearly 100%. So this has been used by people not only for diagnosis to direct the biopsy, but also for sentinel lymph node mapping. And people have used a hysteroscopic directed perilesional injection of the dye and saw better paraortic node rates, although it makes it more complex, so it's not routinely recommended. And in addition, as a fertility treatment, preserving treatment, hysteroscopic resection of the endometrium has been described, which I have to give a disclaimer that I have never personally done this. This is not just removing the endometrium in such a case where there is a cancer, but also some of the underlying myometrium. So we have only given the medical management, but this option exists for any case which may be suitable for it. So there have been concerns about spillage of malignant cells, but these have been shown to be unfounded because there was no difference seen in the course of high-risk endometrial cancer for those who had hysteroscopy and those who had not had hysteroscopy, whether it was positive cytology, stage 4 disease, intraperitoneal disease, or peritoneal dissemination. So where required, definitely you should go ahead to do this one. People have also described the hysteroscopic morphological patterns reflecting the histological grade of endometrial cancer, pretty much akin to the way we look at the vascular patterns in the case of colposcopy. And so any atypical vessels, and the most atypical vessels, whether it is colposcopy, whether it is hysteroscopy, are these ones which become dilated and narrowed. The normal pattern of vasculature is always branching. It should start from thicker, become thinner. The moment you see this type of a situation, that means it is not normal. The moment you see these truncated kind of suddenly ending vessels, these are not normal, or loops, or these zigzags, and pretty much similar to what you are seeing in colposcopy as well. Now, MRI is the method of choice for myometrial invasion and for soft tissue delineation in any organ. So it is the contrast enhanced MRI which we should be choosing, not the plain one, which unless there is a contraindication for contrast. And this will tell us about deep myometrial invasion with a great sensitivity. As compared to that, the involvement of the cervical stroma metastatic nodes is not as good, but the deep myometrial invasion, this is the best thing where you know it. And based on this, you can decide whether your patient goes for a non-fertility preserving or a fertility preserving treatment option. Now, coming to the management, this is one, as I said, where there can be a great role for gynecologists who do not have oncological training also. Abdominal approach and vaginal approach have both been used because in the current FIGO staging, the peritoneal cytology has been removed. So people are there who do a very early endometrial cancer also by the vaginal route, but you have to remove the ovaries. So the abdominal route could be laparotomy or MIS, whether laparoscopic, whether robotic, and endometrial cancer is probably the one where the role of MIS is the most clear and undisputed, unlike cervical cancer, which is very much disputed. So the normal surgical staging is done. Peritoneal washings don't change the stage, but ideally we should take them. So I am not one for vaginal hysterectomy. I will always go for a laparoscopic approach or an open approach, depending on some cases not being suitable. And we do an extrafacial hysterectomy and bilateral salpingo-oophorectomy, and lymphadenectomy is not essential. The important thing is to obtain free margins. So for free margins, we never have to remove the vaginal cuff, really speaking, any longer. Maybe a very rare case which has involved the cervix to that extent. No, it doesn't usually happen. So parametrium involvement, sometimes for the cervical, you may choose to take a little bit of type 2, but it is not a mandatory thing, because in any case, these patients who have involvement of cervix will require radiation. So broadly speaking, most of the cases, the surgery that has to be done is an extrafacial hysterectomy, bilateral salpingo-oophorectomy, with a lymphadenectomy in some cases. So if she doesn't fulfill the criteria for lymphadenectomy, that means you are well authorized to go ahead for this basic procedure. So as I mentioned about the cervical involvement and the adjuvant treatment, and omentectomy is indicated for the serous variety. So this is important to know. And if you are doing minimally invasive also, you can do the omentectomy by the same route. So this was the trial, the GOG LAP 2, which had shown conclusively that the laparoscopic approach was as good as the laparotomy, with fewer post-op complications, shorter hospitalization, a superior quality of life at 6 weeks after surgery, but no difference seen at 6 months, a similar rate of intraoperative complication, no difference in detection of advanced stage, and it was initially showing a longer operative time, but we know there's a learning curve, so this is not essentially true at all either any longer. And the most important thing is that the oncological outcomes were not adversely affected, and the 3-year recurrence rate was similar, and the estimated 5-year survival was also similar. And this has been proved also by the Cochrane that you can go ahead for the MIS, which will give you the equivalent results to laparotomy. And the robotic surgery meta-analysis has also shown lower blood transfusion and intra-op complications, lower conversion rate. This operative time thing, I think, depends on the phase at which it is done in the learning curve. The main thing is you did not have the blood loss post-op complications. In fact, they were reduced in the robotic arm, and there was no difference in the lymph node harvest either. So this is a safe and effective surgical practice. In fact, it is the ideal cancer for MIS, and you can get the specimen removed en bloc. The size of the uterus must be such that you can remove it without cutting it. So it should not be more than an 8-week size uterus, ideally max to max 10 weeks, because you cannot cut it to remove it. That is the one gold standard rule that you must follow. Coming to the contentious issue of lymphadenectomy, which has been discussed for last 2 decades, to do or not to do. And now this Cochrane review showed that there was no differences in OS and the overall survival and recurrence-free survival or the morbidity, but a significantly higher risk of surgical-related systemic morbidity, lymphedema, lymphocyst formation if you do it. So it did not overall decrease the risk of disease recurrence compared with no lymphadenectomy in women with presumed stage 1 disease. So the ESMO-ESGO-ESTRO consensus has happened with all of these things, and they have shown that if it is a low-risk tumor, then it is not required to do lymphadenectomy. Intermediate risk may be for staging. Only in the high, intermediate, and high risk is it to be done. So which are these high-risk cases where it should be done? If it is more than 2 centimeter size of growth involving outer half of myometrium, this you will know from your MRI. If it is moderately or poorly differentiated, a high-risk histological subtype, this your pathologist will tell you on the biopsy. Having said that, I have to say that you must remember that there may be a difference in their final answer, but we have to go with what we have at that time. If the cervix or the adnexa again are looking involved on the MRI, or if there are enlarged or suspected pelvic nodes and para-aortic nodes, these are the cases where you need to do the lymphadenectomy. Other cases, they need not have a lymphadenectomy done. Now, the sentinel lymph node has been a paradigm shift in the surgical staging. It is the first node to receive the metastasizing cancer cells, and it can detect micromets and tumor cell, isolated tumor cells. If you don't do the whole lymphadenectomy, you can be saved the complications of lymphadenectomy, the injury to the vessels, the ureter, the longer surgery, paralytic ileus, lymphedema, lymphocele. These are realistic problems that can occur. So the sentinel lymph node gives a viable alternative. What it does is to inject the ICG tracer. So, you know, the ICG, which was first available in the robotic system, then it came in the laparoscopic system, and now it's even there in the open handheld systems. So this gives the best results because methylene blue dye has been used, but that has a very rapid disappearance really. And even with the radio tracers, which are of course not universally available, is a problem. So here you just have to inject the ICG solution into the cervix at the 3 and 9 o'clock. Remember, I told you some people are doing hysteroscopic, but that is not at all essential. And you can just do this injection and you can visualize the ICG tracer in the lymphatics. You see where exactly it is going, the channel from the cervix to at least one candidate lymph node, and you retrieve that and label it for location and send it for the pathology, which has to be done in a very special way, in which you have to, this one is a robotic one, where it is being followed, the tracer is following it, and it is seeing which is the first node which gets it, and that one is then dissected out and taken. In case a sentinel node is not identified, then that entire side lymphadenectomy will need to be done. So you need a pathologist on board for this, because it's a very specific way in which you have to process the lymph nodes. So this is just to show you again this thing, and then they have to do what is called the ultra staging and cut multiple very, very close sections to see it. This was the FIRES trial, which compared the sentinel node to the entire lymphadenectomy and found a sensitivity of 97.2%. Moreover, in many cases, they found them in very unconventional spaces. The first node in the sacral or somewhere where you may not even have taken it off if you were doing the entire lymphadenectomy. And this was very useful. More recently, we had the SHREC trial, which looked at the sentinel lymph node also for the high-risk endometrial cancers, which means the Figo's grade 3 endometrioid cancers, the non-endometrioid histology, 50% invasion, cervical invasion, and even this they have found the sentinel lymph node algorithm was very accurate. Now coming to the adjuvant therapy and looking at the risk stratification, the ESCO classification. So as I said, they have got now the low grade risk, the stage 1, grade 1 to 2, less than 50%, LBSI negative, intermediate if it is more than 50%, high intermediate if it is a grade 3, regardless of LBSI status, high if it is more than 50% invasion, stage 2, stage 3, non-endometrioid, and the advanced if they are stage 3 with residual disease, and stage 4A, and metastatic if it is stage 4B. So they have recommended the adjuvant therapy based on these stages. And as I have been saying now repeatedly, low risk does not have any adjuvant therapy. The low to intermediate risk need to get only the vaginal brachytherapy. Only vaginal brachytherapy makes it so much better from side effect point of view. In the high to intermediate risk, they get the EBRT only if the LVSI is unequally positive, and especially if the lymph node dissection has not been performed. And the high risk are the ones where really you give the EBRT to all these patients, and you will have the non-endometrioid then, which will have for the not just the vaginal brachytherapy for the stage 1A, but also the combined chemo for the 1B to 3. So this chemo is usually the carboplatin and paclitaxel, just as we give for ovarian, 6 cycles of 3 weekly chemotherapy. But if we will go back to the story of the molecular classification, this study is going on to PORTEC-3 to see how the molecular category can impact the 5-year survival in chemoradiation and in the radiotherapy arms. And it becomes clear here that the polymutated do really, really well as compared to the NSMP, MMRD, and the worst outcome is in the P53. And so they hypothesize that you can give the adjuvant therapy based on the integrated risk profile. So I spoke about hormone therapy. Yes, it is indicated for the recurrent or metastatic cancers, especially where there are well-differentiated tumors with ER/PR receptors. There has been a long disease-free interval. We use of medroxy with alternating, estrol acetate with tamoxifen alternating, and Megase is also now available in India for many. Previously, that used to be an accessibility problem. So it is good to evaluate the hormone status before initiating therapy. The biopsy of recurrent disease is also to be done because of differences in hormone receptor and metastatic tumors. Immunotherapy has been recently approved, again going with the molecular classifications. The pembrolizumab is effective where there's MMR deficiency, and FDA has approved it for all solid tumors with MSI or MMR deficient, including endometrial cancers. MMR approved for the endometrial cancers that are not MSI high or MMR deficient, and these have this disease progression following prior systemic therapy, but are not candidates for curative surgery or radiation. Is still a little bit in the experimental zone, but this is very much coming. So coming back to the story of the fertility sparing treatment, which we had talked about their evaluation previously. And this is possible because now, as I said, this PCOS patients, very high risk, definitely we see in them, but even the others are coming forward. But the fertility sparing is for the well-differentiated endometrioid adenocarcinoma limited to the uterus, no suspicion of metastatic disease, and no contraindication to the medical therapy or pregnancy. The counseling is very important to tell them that there is a risk involved. So you give a continuous progestin-based therapy, do their endometrial sampling every 3 to 6 months. If there is a complete response by 6 months, you can encourage conception with continuous surveillance. And usually they do require assisted reproduction. If the endometrial cancer is present by any chance, then you abandon this conservative approach and go for the full surgery. So what we do is either MPA 400 to 600, so very high dose, or Megase 160 to 320, or IUS with or without the GnRH analogs. Durable complete response is seen in 50% of cases, and about a third of them will get pregnant, a third of them will have recurrence. Now, hormone replacement can be given for these patients. It does not really show that there's a risk of recurrence. So for the low risk of recurrence patients, it is possible, but we should wait for 2 years after treatment before starting this treatment. So I will conclude this talk now by saying that the incidence of cancer endometrium is increasing with changing lifestyle. The risk factors are well known and modifiable. Precancerous lesions should be identified and treated early. The 4 major groups have been identified at the molecular level that allow the prognostic differentiation and tailoring of adjuvant therapy. MIS is the standard of care. Lymphadenectomy is not required in low-risk cases. Sentinel lymph node is being increasingly adopted for early stages, and fertility-preserving treatment can be considered. So this is about the FIGO cancer report of 2021, which came out last year. We bring it out every time there's a FIGO conference. It's a free download from the FIGO website. It has always the 6 chapters, which are updates on the cancers, and 6 chapters, which are general interest chapters, which vary in each edition. So please look into it if there are anything, questions that you would like related to oncology. So with that, I will stop this presentation. Thank you for your patient hearing, and welcome if there are any questions.
Thank you, Dr. Neerja. It was really a masterly talk on the subject. Your erudite and your authority was palpable. I am so happy and thankful to you for accepting our invitation and giving such a wonderful talk, which I am sure is so useful to all those who have attended today. And I am sure when we put it on the YouTube, it's going to help all the gynecologists in the country. Today, I learned a lot of things, especially the hysteroscopic evaluation, something like colposcopic evaluation of the endometrial thing, and sentinel lymph node. I always had to have a debate with my assistant regarding the removal of the lymph nodes. You clarified it so well. And I'm sure in coming days, it's going to be more and more elaborate and clear. And you also touched upon the robotic surgery aspect of it. One just question I had, they say that in ovarian cancer, robotic surgery can spread the cancer. Is such fear there in endometrial cancer? Because of the high pressure of the pneumoperitoneum.
You know, the theories of why we see certain cancers to spread and certain cancers don't, including cervical cancer, also not very, very clear. Is it that we are missing out some disease which is lurking in some corner where we are unable to palpate it, or is it that high pressure or whatever? But okay, like they say that the proof of the pudding is in the eating. So when the randomized control trial is showing that the oncological equivalent is outcomes are there, the oncological outcomes are equivalent, then we don't really worry so much, because that shows very clearly that the disease-free survival, the overall survival remains just as well. But one thing which is there also in that, which is worthy of note for those who don't do MIS, that they should not be deterred about that, because if you have identified properly your well-grade tumor, well-differentiated, less than 2 centimeter, no myometrial invasion, and you have decided she's low risk, you can do very well with the phalansteal incision, the same outcome of surgery. And 6 weeks, yes, they have seen the difference, but at 6 months, there is no difference. So that means that if there is a patient who is very active, she needs to get back to work, she can't wait. For that patient, maybe it matters that at 6 weeks, she has achieved a better outcome. But for the patient who has time on her side and doesn't care that she takes a little longer, then there is absolutely no difference in that case, in any case. So it is a very encouraging message on both fronts. So if you are doing MIS, very good, go ahead, nothing better. If you are not doing MIS, it's also good. The main thing is identify the case by a proper preoperative image and a proper histopathological evaluation by a good pathologist.
Thank you, ma'am. Thank you for clarifying that. I also felt the progesterone dosage for fertility, those who ask for fertility management after this, was little too high, isn't it? Have you ever used such high doses?
It's got hung.
Okay. Over to Dr. Bharati to take the other question and answer sessions.
Dr. Nirja, Madam, it was an excellent session. And of course, you have really enlightened all of us consultants about what is the molecular genome study, the genomic characterization, and how it affects the prognosis of the disease. Though most of us do not have access to it, it's good that we know about it so that we can offer these services to our patients. And you have a lot of complimentary comments on the chat box. And I have a question for you, Madam. What in our clinical scenario could we take up as the risk reducing modifications or lifestyle modifications that we could take up in our day-to-day clinical practice?
So I think two things I want to say. For the molecular studies, by the way, people are sending to Bangalore for some 18,000 rupees. They are doing this. So some patients may be there who have the affordability and would like to know. So please keep in mind for those. But yes, nobody is doing it as a routine. Even we are not, definitely not yet. So for the lifestyle modifications, the first thing is to control the body weight and especially the abdominal fat. That is a very, very important risk factor. And the second is diabetes. And these are the two most important in our hands. The third question, which the young girls will or will not agree, is that they should go for pregnancy within their 20s and not delay it too long, because nulliparity is a factor, and giving that break to the system when you have the 9 months of pregnancy, when you have the 6 months of lactation, is an excellent thing for us as a preventive measure for endometrial cancer. We know that. So these are the things which are possibly in our control. And apart from that, as warning signals goes, I think in the premenopausal, it's sometimes a little more difficult to diagnose because a heavy menstrual bleeding may not manifest as dramatically as a postmenopausal bleeding. So even a heavy premenopausal bleeding should be looked into and investigated. And a transvaginal ultrasound is an excellent tool as a first point. But postmenopausal bleeding definitely should not be ignored. In fact, most times is not ignored. And that is why endometrial cancers, it is estimated that they usually present within 3 months of the occurrence of the bleeding. It is a very dramatic event. So people should be encouraged to report any such bleeding. I saw a patient who looked like educated, and she said, I thought, doctor, my periods have started again. And, it's amazing what all misconceptions can be there. So we should make them aware that this is not normal. This needs to be investigated. And most of them will be fine. If any family history is there at all, then at least an annual checkup is required, and very strong family history may even be recommended twice a year checkups.
Thank you, madam.
Okay, thank you, madam. Just wanted to know, thank you, madam, for excellent lecture. It was really very informative, especially the sentinel lymph node biopsy, which we are not routinely doing here. And whenever if we take a help of a general oncologist, they prefer doing lymphadenectomy, even if it is like borderline. So they tell always, even if it is lesser grade. So very thank you for highlighting on that sentinel lymph node. So we can really select patients whom to do and whom not to do this lymphadenectomy. One more thing I wanted, madam, just wanted to know your experience on this conservative management of these patients.
So it works, in majority of patients we have seen it is beneficial and it works, but the pregnancy rates may not be as good. And it is only for the ones who are the well-differentiated cancers. So in the majority, I would say 60 to 70%, we do get good response to the hormone. I had once a patient who was diagnosed as C endometrium outside, but when we reviewed, it says only complex hyperplasia with atypia. So we gave her progesterone and she responded well. And then she tried conception. She did not conceive, so she went to ART, she conceived. We said, after the pregnancy, you have a hysterectomy. In fact, we had even prepared her for cesarean hysterectomy if she should. But I think I will tell my story another time.
Yes, madam.
So she had the delivery. Anyway, after 2 pregnancies only, when she had the hysterectomy done.
After 2 pregnancies?
2 pregnancies.
Actually, at the 1 pregnancy also, so we are so much the thing.
She said it's a girl. After the first one, she says it's a girl. So she did not have, and she had an LNG. Then she had another ART pregnancy, and it was a boy. Then she said, my children are too small. But then again, she was having irregular bleeding. I said, now if you develop cancer, I am not going to manage you, so you better get it done. And they literally forced her for a TLH BSO. But recently we had a doctor, came from Kashmir, and she had a progression. And it was all confined and no invasion. And while she's taking the hormones, she had a definite evidence of invasion in the MRI. And we said, you have to go for definite treatment, but she is still thinking about it. And she's a doctor. So it's a very difficult thing sometimes to convince patients,
But how do they fare well in pregnancy? Do they fare well?
Again?
During pregnancy, any complications?
No. Pregnancy has been quite uneventful for all our patients.
And when do you plan for hysterectomy? Immediately after 6 weeks or so?
It's not necessarily after 6 weeks because, the whole system has been made quiescent. And especially if there was an atypical hyperplasia, I think you can give a little time, even up to 6 months, put in a Mirena and let it be for whenever they are ready in 6-8 months. But if it's malignancy, we should do it within 6 weeks.
Within 6 weeks, okay. Anytime you have planned for cesarean hysterectomy also, madam, during this? But it is sometimes difficult to remember.
First patient, we told her, if you have a cesarean, we should do the cesarean hysterectomy. Okay. But neither she required the cesarean and neither we did that hysterectomy. Second time also, she had conceived in ART, but she had normal delivery.
What was the age group of this patient?
Oh, the first one, in fact, was very atypical. She was not even PCOS and she was a lean, thin patient, but it was well differentiated. And she was in 20s. She was just hardly 27, 28.
Because 27, 28.
Yeah, and even the ones who are telling 30s, they are all in that age group of 20s to 30s. Early 30s.
Less than 30.
That one was less than 20, 30, which I'm telling you, and most of them are in the 30s.
Do they have any positive family history, madam, these patients?
No, but they usually have polycystic ovaries. Usually. We are even seeing some infertility patients with CIN when they are routinely evaluated, which has no bearing, but it is there. Maybe it is some cervical factor caused by it.
Madam, I had seen one case, madam. I had seen a case where that patient presented with a brain tumor and she was operated by a neurosurgeon. And then it turned out to be adenocarcinoma. Then when she was evaluated, it was found that she had C endometrium. She had irregular periods, little menorrhagia, but she didn't gain much importance to that. Only when she had severe headache, vomiting, and some kind of neurological symptoms, then she has not gone to a gynecologist. Of course, she has gone to a neurosurgeon. He has operated. And then retrospectively, it was found that it was a case of C endometrium and the secondaries in the brain
Most unusual.
And that patient's age was only 32. That is one case which means how can like such young age means any predisposing factor, or means how she presented directly as a mets in the brain.
Dr. Jamuna has a question. Yes, Jamuna, you can.
Ma'am, I have 3 patients who are in their late teenagers. PCOS case, they have hyperplastic endometrium. So now with this background, should we evaluate all these people for CA endometrium?
So you are saying endometrial hyperplasia based on ultrasound?
Yeah, no, on histopathology, because they had heavy bleeding, endometrial thickness too high. I had to do a histoscopy directed endometrial biopsy. So
And that
these
is
people,
showing atypical
yeah,
or no
in
atypia?
2 of them it is atypical, in 1 it is simple hyperplastic endometrium.
So if they have atypia, they should definitely get the they should have an MRI to look at the junctional zone and all that, of course, but they should get high dose progesterone for 6 months.
Okay.
So, madam, do you advise what dosage do you advise the progesterone for such individuals?
So we advise usually for the megestrol acetate, 160 milligram BD we advise. That is our first choice. Other option is to give the LNG IUS and give the GnRH.
Along with the IUS, give them the. Okay, thank you. Madam, and you said that as a regular gynecologist also, we do come across the endometrial CA and we may operate on them also. But what are the medical legal implications when we take up a case like this and we do the surgery? Is it medical legally, will there be any implications?
So I think once you have done MRI, you have seen that the tumor is less than 2 centimeter diameter. You have seen that there's no enlarged lymph nodes being reported in the abdomen and pelvis. And you have seen that there is no involvement in the cervix and adnexa. You have got your pathologist reporting it as a well-differentiated endometrial carcinoma. Then I think you are well within your rights to go ahead with the surgery, keeping a backup of somebody in case intraoperatively you find the cut section is showing some very large tumor or something which was totally unanticipated. If the MRI was done more than a month ago, we have seen the findings may change. So at least one ultrasound should be repeated if the MRI was some time back, so that we are confirming at least broadly that there's no much change.
Thank you, madam. I think you have given a very, very good insight into the personalized modification of management of women with endometrial CA from the age of reproductive age group to the menopausal age group. We thank you, madam, for having spared your valuable time and shared your very, very recent inputs about endometrial CA to our audience. And they are all immensely pleased with all your inputs and the clarity with which you have put it across to all of us and given us the take-home messages of how we have to always keep it at the back of our mind, even if she's a younger individual, abnormal uterine bleeding, please look in for endometrial abnormalities and keep it in mind and keep that, like as you said, age is not a criteria for having an endometrial CA. So thank you, madam. And now I request our Joint Secretary, Dr. Manjula Patil, to propose the formal vote of thanks. Thank you, madam, and namaste from my side.
I have a doubt, ma'am, because PCOS is such a common, findings disease nowadays. Do we need to do endometrial biopsy for those with the endometrial hyperplasia? Because if the patient is not getting the cycles for 2 to 3 months, sometimes even 4 months, is it not natural to have that she is having the endometrial hyperplasia?
So it is said that we should look in the post-menstrual phase. And if the endometrial thickness is more than 11 millimeters in the post-menstrual phase, then it is a matter of concern. So we should give them a withdrawal. If they have not had period for 2-3 months, you can even give them a hormone withdrawal and then check the ultrasound for the endometrial thickness. If it is more than 11 millimeters, it should be sampled.
Post menstruation means what exactly, what day you would like to?
Usually we'll say between the 7 to 10 days.
Fine. That is a very good information, ma'am. Thank you so much, ma'am. That was indeed an excellent and very informative talk on CA endometrium from adolescent to menopause and post-menopause. Actually, all the audience really enjoyed your talk, and we are indeed very happy and proud to have you over here. Thank you so much, sir. Big round of applause for you from all of us, from all the KCOG members. And I would also thank Pai sir for providing you as a speaker today. Thank you so much from the bottom of our heart to you, ma'am. And at the outset, I would also thank all the KCOG members and Kcog office bearers and EC members joining over here. Thank you, Kasturi ma'am, for providing such a nice topic on this platform. And I would like to thank our Honorable Secretary Dr. Bharti ma'am, who's always encouraging and backbone for all these academics. And I would like to thank Dr. M.G. Hiremat sir, who could not able to log in today. I would like to thank Dr. Sajjan sir, who's a past president. And I would like to thank our joint secretary, joint treasurer sir, Dr. Durga Das, and all the EC members, and Vidya Tobi ma'am was always there for all the Foxy and all these Kcog programs. Thank you, Dr. Murli sir, for being over here, and Hema ma'am, Vidya ma'am, thank you so much. All the EC members and office bearers. It was a wonderful session, and all the audience who could able to make this a grand big success. Thank you one and all. Thank you one and all. Good night.
Thank you. Bye.
Thank you, Manjula.
Bye.
And thanks once again to everybody. Have a good night's sleep and a safe weekend. Namaste.
Thank you, ma'am.
Thank you, madam.
Night all.
Murli sir ಹೊರಟಾಗಿದ್ದಾರೆ. Murli sir has a party.
Oh,
Graduation, some graduation, their postgraduate, some function. Hi, Sonia.
Thank you, Bhakti.
Thank you, madam.
Thank you.
Congratulations, ma'am.
Congratulations.
Very informative.
Very
Yeah,
well.
It was really very nice topic.
Actually, Manjula, tomorrow morning I am doing an endometrial hysteroscopic biopsy for a lady. She is para 2. She's not tuberculized, but she's been having this irregular menstrual bleeding. She's fine when she's on OC pills. She stops the OC pills. She starts bleeding continuously. Her endometrial thickness today was 17 millimeters. Okay. So tomorrow we plan to do an endometrial, probably these are endometrial biopsy under hysteroscopic guidance. Probably these are the women who are at a high risk. She's a thin PCOS, but she's been having this persistent abnormal uterine bleeding, and the endometrial thickness, in spite of 1 month bleeding now since the past 1